Bismillah ar-Rahman ar-Rahim. Our subject today, Shabab, would be about malabsorptive syndromes in children. Malabsorption occurs when the normal digestion and absorption of food is interrupted. They are classified according to the cause, either due to impairment of intraluminal digestion or impairment of the intestinal absorption, which means a mucosal defect in the intestine, or a fermentation disorder, that is, malabsorption of usually the carbohydrate part of the food, which leads to the fermentation of the unabsorbed sugars. In many conditions, more than one factor work to produce the symptoms of malabsorption. The normal digestion runs into three courses. The first one is the luminal digestion, usually concerned with pancreatic enzyme digestion working on the food. The other phase is the mucosal digestion, where the brush border of the small intestine is covered by certain enzymes. Mostly they are the disaccharidases. And the other part of the absorption is the mucosal absorption through the small bowel mucosa and its lymphatics. Examples of malabsorption: the luminal maldigestion usually affects fat in conditions of chronic pancreatitis. Mucosal maldigestion, where deficiency of disaccharidases, for example, lactase deficiency. Mucosal maldigestion and malabsorption, for example, what happens in celiac disease. Comparing malabsorption versus maldigestion, malabsorption usually stands for defects in the mucosal phase, while maldigestion points to defects in the intraluminal or the enzyme deficiency. Long lists of causes of malabsorption due to intraluminal failure of digestion, for example, cystic fibrosis, another congenital defect in the pancreatic activity, which is the Schwarzman-Diamond disease, biliary obstructive diseases, and other long lists. Intestinal malabsorption, the classical example is celiac disease. Very long list of mucosal causes of malabsorption, including even Crohn's disease and autoimmune enteropathy. Fermentation disorders, for example, lactase enzyme deficiency, which may be congenital or acquired following an intercurrent viral enteritis. It may present in childhood or even until adulthood. In the primary forms of maldigestion, the small intestinal histology is usually normal. In general, symptoms of malabsorption, usually as chronic diarrhea, more than 2 weeks duration, slow growth or even weight loss, distension of the abdomen or bloating, wasting of the subcutaneous fat and even muscle wasting, vomiting, anemia due to iron deficiency or megaloblastic anemia due to folate and sometimes even B12 when there is extensive intestinal damage, edema due to hypoproteinemia, and symptoms of vitamin deficiencies, rickets for vitamin D, bleeding for vitamin K deficiency, glossitis and paresthesia due to vitamin B complex deficiency. When we face a patient, a child with features of malabsorption with chronic lung disease, think of cystic fibrosis or congenital immune deficiency. When we face a child suffering from fever and weight loss in addition to malabsorption, usually one would think of TB or lymphoma. General investigations for suspected malabsorption include blood test, stool examination, imaging studies, endoscopy with biopsy and aspirate from the duodenal content, the breast hydrogen test, and sometimes, rarely, we need the D-xylose Schilling test also. What blood tests are usually performed? The complete blood count and looking at the blood film, anemia if present, which type of anemia, the electrolyte level, the sodium, potassium, chloride, in addition to the calcium, phosphorus, magnesium, which may be affected by vitamin D deficiency, the albumin level, certain vitamin and trace element levels. The stool is useful, macroscopical appearance, the presence of blood in the stool, ova and parasite, the pH and reducing substances, which is useful to detect unabsorbable sugar, which is the fermentation type of malabsorption. And rarely we need quantitative fat estimation. The characteristics of a fatty stool, which is especially seen in malabsorption due to intraluminal impairment of digestion. The stool is usually bulky, it floats, bad odor, and it is difficult to flush from the latrine, from the toilet, because it is very sticky. While the fermented stool, due to sugar malabsorption, is usually watery and frothy, with a sour smell, ريحة حموضة, and it has got a lower pH. So watery and frothy stool due to the production of volatile acids. Imaging studies in general in the form of barium meal and follow-through, which may show flocculation and segmentation of the barium column. Sometimes CT or magnetic resonance interrography is done after giving a contrast material to the patient, or even endoscopic enteroscopy. This is the classical picture of the barium meal and follow-through, where it shows flocculation of the barium, smudging of the barium, and interruption of the column of the barium, with areas of dilatation. The classical endoscopic appearance, again, it is not pathognomonic of a disease per se, but it may be seen in several types of diseases. The duodenum would show a decrease in the folds, scalloping, and mosaic patterns. This is what we mean by the mosaic pattern. Sometimes they call it baklawa-like. محززة كأنما معينات. The histological appearance, it can be diagnostic, يعني ينطينا diagnostic straightforward, or it supports a diagnosis ما تحددها بالذات, but تنطينا list of differential diagnoses, and sometimes it is normal. So back to our subject of malabsorption. This is an electron microscopic view of the small intestine, showing the finger-like projection of the villi of the small intestine. This is the normal look of the healthy small intestine. While in contrast, this is another view of electron microscope, where you can see that the villi were blunted, shortened villi, or nearly flattened intestinal mucosa in cases of malabsorption. This is called partial villous atrophy. Again, this is a histopathological appearance of the normal villous pattern seen in the small intestine. You can see it is called feathery-like, مثل الريش, tall and long villi with somewhat shortened crypts. This is the normal appearance. In contrast, you can see that this is totally flattened mucosa. There is no any projections, no any villi, and at the same time there are deep crypts. These slit-like areas, they are the cryptic area, and they are so deepened. In addition, you can see these heavy blue dots, which represents the heavy inflammatory cell infiltration of the lamina propria and of the epithelial cell itself, of the surface epithelium. What are the causes of villous atrophy? Now again we are talking in general. So there is a long list of causes for villous atrophy. One of them is cow protein allergy, the cow milk allergy or the soya protein allergy. The other cause is celiac disease, so it is not pathognomonic for celiac disease. It can be seen also in giardiasis, and what is called the post-enteritis syndrome, which starts as a routine viral enteritis, but the child fails to recover from the illness due to the temporary villous damage done during this infection. So all these may show as villous atrophy, partial or total villous atrophy. So we can regard that histopathological evaluation in such conditions gives a supportive diagnosis rather than a specific diagnosis, because the picture of villous atrophy would give a suggestion of possibly diagnosis of one of these diseases. When would be the intestinal biopsy of diagnostic value? Specific diagnosis is seen when we can find dilated lymphatic vessels in the intestinal biopsy, which represents intestinal lymphangiectasia, which can be a congenital defect or sometimes acquired after obstruction to the lymphatic channel. Anyhow, such patients usually present with chronic protein-losing enteropathy states, and the small intestinal biopsy is usually diagnostic. In another condition, it may be diagnostic when we can find vacuoles filled with lipids in cases of abetalipoproteinemia, which is a congenital defect in the pancreatic function and associated with impairment of the lipid absorption, with specific retinal changes in the shape of retinitis pigmentosa and acanthocytosis seen in the blood film. Anyhow, it is a sort of congenital pancreatic deficiency, and here also the small intestinal biopsy is of diagnostic value. Non-specific changes اللي وصفناها إنه تنطينا supportive diagnosis when you find villous atrophy, because as you have seen there is a significant list of differential diagnoses in villous atrophy. So a common disease is the celiac disease. How do we define it? It is a sort of small bowel mucosal damage due to permanent sensitivity to gliadin. So it is a permanent, lifelong sensitivity. It is an autoimmune disease in which the lining of the gastrointestinal tract is damaged by an immune-mediated response to gluten proteins. It is a polygenetic disease that only appears in genetically susceptible individuals. When we say polygenetic, we mean that we need a genetic predisposition, but in addition we need environmental triggers to elicit the state of celiac disease. Approximately 90% of individuals with celiac disease, they carry a specific HLA pattern, which is called the HLA-DQ2 haplotype. The remaining 10%, usually they carry the HLA-DQ8 haplotype. And when a patient lacks the DQ2 or the DQ8, in such conditions, usually the diagnosis of celiac disease is questionable. Such patients, usually they have a family history of the same disease in about 25% of condition. It means that there is a high prevalence of positive family history. As we have said, it is immune-mediated destruction of the enterocytes in response to the gluten which is present in the wheat and certain other grains, for example, the barley, الشعير, الحنطة والشعير, and some types of the oats. The histological damage done in celiac sprue is usually patchy, and usually it affects the proximal part of the small intestine more than the distal intestine, probably because the gluten particles, whom they are the noxious agents, when they are hydrolyzed during the passage inside the intestine, they become less and less harmful to the mucosa. So this is why the proximal part, which faces the intact molecules of the gluten, is damaged more severely than the distal areas of the small bowel. Mucosal digestion and absorption both are severely impaired. It means that there is histological damage to the mucosa, and in addition, loss of the enzymes that reside on the intestinal villi, which are the disaccharidases. So the mucosal digestion phase is lost and the absorptive phase is lost. Usually characteristic antibodies are seen, and they are useful in the diagnosis of such condition. So in the blood, the IgA antibodies are found to the tissue transglutaminase or to the gliadin. Both they are diagnostic for the condition. So the immune villous damage, again here you can see this is the normal feathery appearance of the normal small intestine in contrast to the totally flattened mucosa, no any projections, while they have a very deep crypts and dense inflammatory cell infiltration to the epithelium. How does it present? It usually presents in children under 2 years of age and within 6 months of starting cereals. Within 6 months, يعني it may start within 1 month. After 1 month of starting the cereals, for example, it may start after 3 months, after 6 months onward. So it means you cannot suspect the disease in a baby who is totally milk-fed, whom he didn't start cereal ingestion yet. يعني لازم يكون ماكل شيء من الحنطة أو الشعير لفترة حتى to start the symptoms of the disease. The child usually ceases to thrive and he becomes irritable. Less commonly, this disorder manifests in adult life and occasionally even in elderly patients. There is often an association with other autoimmune diseases like type 1 diabetes mellitus, autoimmune thyroid disease, vitiligo, etc. In general, the clinical manifestation of celiac disease nearly similar to other malabsorptive conditions. There will be weight loss, often with an active increased appetite. The character of the stool is usually bulky, oily, steatorious stool. Lot of flatus, frothing in the stool due to carbohydrate malabsorption, because we have said that there is affection of the mucosal digestive phase. Anemia is frequently seen. Initially, in the state of celiac disease, it is due to iron deficiency, but if it remains untreated, superadded folate deficiency and sometimes even B12. هذه مرتبطة بالarea affected in the intestine. احنا قلنا the first part that would be affected by the damage is the proximal part of this small intestine, which is the part concerned with the iron absorption. So iron deficiency becomes first, then the folate, which is absorbed all along the small intestine. Whenever there is extensive damage to the small bowel, there will be additional folate, and B12, which is absorbed in the distal part of the ileum. Commonly, they have osteopenic bony changes due to vitamin D and calcium deficiency, because vitamin D is a fat-soluble vitamin and they have steatorrhea. Edema due to hypoproteinemia, different vitamin deficiency states. The classical manifestation is usually seen in the under 2 years of age, which is diarrhea, steatorrhea, anorexia, growth retardation, probably even weight loss, vomiting, pallor, abdominal distension, bloating, large bulky stools, and even digital clubbing. This is the typical classical presentation, usually is seen in the first 2 years of life, severe wasting with significant bloating of the abdomen. The nutrients. So, what investigations are required? The routine investigations in any case suspected of malabsorption. In celiac disease, usually we have the serological testing that I have already mentioned, which is namely the anti-tissue transglutaminase IgA antibody, which is usually positive in such patients. But a point to be kept in mind, there are some children whom they have a congenital deficiency in the serum immunoglobulin A, in the serum IgA. And such patients usually are even more susceptible to develop the celiac disease. So in such conditions, there may be a false negative serological reaction to the anti-tissue transglutaminase. So it is preferred to measure the total serum immunoglobulin A at the same time that we measure the anti-tissue transglutaminase A, in order to make sure that if the anti-tissue transglutaminase is negative and the total IgA is low, so we can appreciate that it is a false negative reaction. In that instance, we may perform the anti-tissue transglutaminase IgG type of antibodies, which are usually found to be positive. Another serological test is the anti-endomysial antibodies. Again, they have two types, the IgA and the IgG type. The IgA is the one which is more sensitive, but again, we need to correlate it with the total serum immunoglobulin A of the patient, because if it is low, if it is deficient, there will be a false negative reaction to the anti-endomysial IgA antibody, and again, we will need to look at the IgG type of antibodies. The diagnostic, or the gold standard in the diagnosis, is having a biopsy of the small intestine to ensure the diagnosis of celiac disease, in which the classical appearance will be shortening of the villi, which is in the shape of partial villous atrophy or subtotal villous atrophy, or sometimes in severe conditions that you have seen in the previous slides, we may see total villous atrophy with flattening of the villi. In addition, there will be deepening of the crypts and dense inflammatory cell infiltration in the epithelial cells, increased in the intraepithelial lymphocyte. This whole picture represents the findings in celiac disease. This is the celiac iceberg, which represents that the symptomatic cases of celiac disease are only a minority. There are a lot of other patients whom they are harboring the silent type of celiac disease. They may have a positive serology, but they do not show the symptoms yet. What is the treatment for celiac disease? A lifelong, strict, gluten-free diet is the available treatment until now. So it is not a temporary condition, it is a permanent sensitivity to the gluten, so it needs a lifelong, strict, gluten-free diet. Initially, when we start the gluten-free diet, we may need to support the patient with iron, and vitamins, the fat-soluble vitamins, especially for a month or two while continuing on gluten-free diet. And the gluten-free diet, it means a diet which lacks the wheat, الحنطة, the barley, الشعير, and sometimes even the oats. Another subject that may lead to malabsorption is chronic Giardia lamblia infestation. It is very frequent in our society, which is regarded as an endemic one. The major reservoir or vehicle for spread it is a water contaminated with cysts. The human breast milk is lethal to the Giardia trophozoite through the action of fatty acids present in the human milk. The human milk protection against Giardia correlates with the anti-Giardia serum immunoglobulin A present also in the breast milk. The types of Giardia presentation, it may be asymptomatic. The other type of presentation is acute watery diarrhea. The other type of presentation is chronic persistent diarrhea. The other type of presentation is as malabsorption, where the child would show a foul, greasy stool with flatulence and weight loss, a picture that simulates celiac disease. Blood, mucus, and pus cells, we mean by fecal leukocytes, they are absent. So no blood, no mucus, no pus cell is seen in the stool of a patient with Giardia infection. Abnormal stool patterns, I mean diarrhea or steatorrhea stool, can alternate with constipation and normal bowel movements along the chronic course of giardiasis. The diagnosis is done by detection of the trophozoite, cyst, or antigen in the stool or duodenal fluid. So the trophozoite is rarely seen in the stool, but frequently we see the cyst, and we can do antigen detection on the stool sample of the patient. The trophozoite is frequently seen in the aspiration of the duodenal fluid if it is exposed to microscopical examination. The stool specimens should be examined within 1 hour after being passed or should be stored in vials containing polyvinyl alcohol or 10% formalin. Trophozoites are more likely to be found in unformed liquid stools because the rapid transit time will allow the trophozoite to reach to the exterior. So with solid stool, usually the cysts are seen. Cysts but not trophozoites are stable outside the GI tract. So the stool sample should be examined immediately within 1 to 2 hours because very soon the troph will become encysted and change into the cystic form. The duodenal specimens obtained through aspiration of the duodenal fluid or a biopsy of the duodenum and small intestine, the trophozoite can be seen on direct wet mount. So where can you see the trophozoite? We can see it in the duodenal fluid aspirate, or when performing routine biopsy from the duodenum, it can be seen sticking to the mucosal surface of the duodenum. Otherwise, what we see in the solid formed stool is the cyst, unless we can get a liquid stool sample, probably there is a chance to find the trough. In addition to these steps, the antigens of the parasites may be found in the stool, which is a very useful technique actually. The treatment is by providing metronidazole in the dose of 15 milligram per kilogram per day for 10 days, or furazolidine in the dose of 50 milligram per kilogram per day, again for a period of 10 days. The other subject that may lead to villous atrophy is cow milk protein allergy that usually is seen during the first 2 years of life. It may present with picture of allergy affecting the skin, as for example recurrent urticaria, respiratory system as recurrent wheezing, but most frequently as gastrointestinal manifestation in the form of recurrent vomiting, frequent diarrhea, which is sometimes even bloody diarrhea, which may lead to chronic iron deficiency anemia. At the GI tract, partial villous atrophy is seen frequently in such conditions if we perform endoscopy and intestinal biopsy. The diagnosis is fulfilled when the symptoms cease at elimination of the cow milk and they recur back at provocation, which means stopping the cow milk ingestion. The symptoms in the shape of vomiting, diarrhea, GI bleeding, skin allergy or wheeze, usually they subside within 48 hours of stopping the cow milk intake, and they recur back when we challenge the baby with this milk, usually again within 48 hours of reintroduction of the milk. The small intestinal biopsy is indicated only when the differential diagnosis is unclear. So the treatment is by removing the cow milk protein from the diet, which means we use extensively hydrolyzed formulas, and sometimes probiotics are used. The other disease that may present with malabsorption is cystic fibrosis, which is an inherited disease, autosomally recessive inherited disease, multisystem disease. It is characterized by obstruction and infection of the airways, which means recurrent chest infection, plus maldigestion with its consequences. Usually there is paucity, reduction of water in mucus secretion with failure to clear the mucus secretion and increased salt in the sweat. They may present with salt depletion. That means actually heat intolerance, because they sweat excessively and their sweat contains a lot of sodium, so they become hyponatremic and dehydrated very quickly on heat exposure. They may present with nasal polyposis, recurrent sinusitis, rectal prolapse early in life is common, pancreatitis and pancreatic enzyme deficiency leading to steatorrhea, liver cirrhosis may be seen. Most important, they present with recurrent pneumonia ending in bronchiectasis. In the neonatal period, they may present with meconium ileus. That is where a thick meconium would obstruct the small bowel, leading to a condition of small intestine obstruction. In the toddlerhood and infancy period, they start to develop steatorrhea, failure to gain weight with polyphagia, because they are hungry most of the time. During childhood, the problem of malabsorption would continue. In addition to recurrent pneumonia and chest infection, they may develop meconium ileus equivalent, that means recurrent small intestinal obstruction. A picture of liver cirrhosis and portal hypertension may be seen. The standpoints in the treatment from the gastrointestinal side, because the other side of the treatment is caring for the chest, chronic chest infection, treating with the proper antibiotics. In addition, GI-wise, we need to provide a high energy diet, increase in the protein intake, a normal fat intake, but with replacement of fat-soluble vitamins, enzyme preparations, that means pancreatic enzyme replacement, and manipulating the dose to ensure the best absorption for the child.